All right, why don't we get started and people will continue to come in. So welcome everyone. I'm Dr. Livia Shriki, and I'm so excited to have Dr. Lucine Wisniewski here with me. I'm an owner and director of collaboration practices, and I started kind of this training program to train clinicians in kind of more complex issues in therapy and evidence-based practices. And so today I think is a really important topic on working with parents of teens and young adults with complex eating difficulties. Today is one of our fundraising webinars. And so I'm going to put in the chat, we're donating all the proceeds to Feast, which is a, sorry, there we go, which is a global organization that helps caregivers of those with eating disorders, does a lot of psychoed and peer support. And we thought that would be a good organization to contribute to today. So just to introduce Dr. Wisniewski, Dr. Wisniewski is, I think, probably needs no introduction, but she is a leading expert in eating disorders and treatment of DBT and has nearly 30 years of experience. She's an adjunct faculty at Case Western University in Ohio. And the other link in the chat is of the book she and Anita Federici just came out with on the MED DBT protocol, which I'm really excited to promote today. So I'm not going to say, I think I could go on for like 5 minutes with the introduction to you, Lucine, but I've really been lucky to be connected with you over the last few years and being able to work with you and collaborate with you a couple of times. So I'm excited to have you back. And I'm going to turn the floor over to you. Just one quick thing before we jump in is those who are here for CE credits, please be sure to attend the entire talk live from beginning to end. And we will be emailing some links to questionnaires afterwards to complete in order to get your certificate. And that's it. Lucine, over to you.
Olivia, appreciate it. And I so appreciate the opportunity both to spread the word about sort of a treatment that might be able to help people who have not been helped by frontline treatments, but also to be able to help the parents and the caregivers that often struggle right along with them, and to promote Feast, which is an organization near and dear to my heart, which really does provide quite a bit of support and resource for parents when parents are the ones left sort of, and which we'll have a slide about, but being the de facto treatment team when, standard treatments don't help their loved ones. Feast is always there ready to provide resources and talks and other parents who are going through similar problems. Because, one of my most important messages, I believe, is that we can't give up on people who aren't helped by frontline treatments. We have to continue to try new things and be creative. And Feast really does help to provide support, patience, and care when parents are in that position. So don't forget, even $5 helps.
Yes.
All right, so what I'm going to do today is I'm going to talk a little bit, because I feel like in my mind, if you're going to offer someone a treatment that is not a frontline treatment, and again, although our focus today is how do we help parents, you need a rationale. You can't just say, oh, hey, I have this other idea, take my word for it. And so I want to talk a little bit about how people get to treatment in general. What are the frontline treatments? I will not spend a ton of time on that because I'm assuming we all have a frame, but I think it's, again, important to look at statistics and background as we might make a case to someone why we're going to try something new. What happens when you've got you're working with someone who has multiple problems, how we get to DBT as a potential solution to help someone who has multiple problems. I'll talk a little bit about med-DBT. I'll talk a little bit about the other types of DBT for eating disorders. And then I'll spend a little bit of time talking about instilling hope and helping parents set limits, and then have some time for questions. which is a bit to pack in to a little more than an hour, but and if you want to put questions in the chat, you are welcome, but I probably am going to wait for questions until the end. So let's start with, how do people show up for treatment? I love to give talks like this. Livia said that I've been doing this for almost 30 years. Actually, I think I have to update my um, bio because it's more than 30 years, but that's okay. And whenever I give a talk, it gives me the opportunity to sort of think about how I want to teach a particular topic. And so one of the things that I did as I started to think about this talk was go back to the literature about, like, okay, if I want to talk about how to help parents, huh, when I say parents, I don't just mean parents of teenagers or children. I mean parents, period, because if any of you, I have adult children. Just because my adult children are technically adults doesn't mean they're no longer my children, and I no longer care about what happens to them. And that, how do people with eating disorders, whether they be uh, children, adolescents, or adults, how do they actually show up for treatment in the first place? And I think that it's really interesting to think about that. First of all, we know from research that only about 50% of people with eating disorders ever even seek treatment in the first place, right? And that most of the people who might be screened and identified as having an eating disorder don't have an interest in getting help afterwards, right? So we already have a sense that we've got an uphill battle. And when I say we, I mean providers, I mean loved ones, I mean friends, family. That this is not an illness where people say, "Oh, please help me to get better," often. We know in particular with youth, they typically seek help first from family or friends rather than seeking direct help from a professional. And to add insult to injury, 15 to 40% of patients with anorexia nervosa involve involuntary treatment. So that, again, we're already fighting an uphill battle. And so when we're thinking about this in relation to parents, I had a conversation, gosh, who was it with? A neighbor. Just recently, I have a neighbor who has a son who's dating a person with an eating disorder. And she stopped, I was in my garden and she stopped and we were talking. And she said, well, they're coming home to visit, and I'd really like to get to know this young lady. She has an eating disorder. And I said, is she getting help? And she said, no. And I said, well, is your son sort of suggesting that she get help? And she said, well, no, that's not his style. And I said, well, he might consider sort of nudge. I use the word nudge a lot because I don't think we can push people to get help, but we can nudge them. I said, you might suggest that he nudge people to get help, and nudge his girlfriend to get help. And she said, really, I'm surprised that you would say that. I would think that people who are struggle with an eating disorder need to decide that they need to get better on their own. And I said, I think that this is, I think, an important point. I think this is a misconception probably from loved ones. And I'm assuming not so much people in the field, but that the people around them think, well, that I can't push them to get better, I can't suggest they get better. They have to be the ones to decide. And there's a nuance here, right? Like, obviously they have to be the one to decide to some degree. And if we know that most people don't seek help, that much of treatment can be involuntary in nature, that it may give parents and loved ones a little bit more footing to be willing to do that nudging. And so that was the conversation that I had with my neighbor. I'll have to see, because they were coming home this weekend. I'll have to see whether or not they actually took that next step. But that waiting for someone with an eating disorder to say, yes, I want help, may not be the best move. So if we think about pathways into eating disorder treatment, I think this is just to give you a little bit of a sense. A minority is really self-initiated. Most common is a mixed / influenced pathway where family concern, physician referral, partner or friend influence is really a big part of the motivator to get someone to start treatment, and then a significant minority needs really externally driven pushing, ultimatums, where might be medical instability or legal or involuntary care. Unfortunately, this is not an uncommon place for loved ones to be in, especially when someone has not gotten well with standard treatments and may involve life-threatening eating disorder conditions or concerns that we might fall in the middle to the end of this continuum. And this is often where we see parents coming in and saying, what can we do? What options do we have? So what do we know about what helps someone with an eating disorder? So even if they come in and they say that they are willing, what is going to be helpful? And so I was really honored to be a part of the group that was asked through the Academy for Eating Disorders, which is our premier academic organization for the research and dissemination of treatments and study of eating disorders. I was asked to be part of this group of international experts to review the clinical care guidelines that were basically any guideline that was published literally in the world. We took and evaluated and then made some recommendations about, okay, so if someone was going to ask, well, my loved one has binge eating disorder, my loved one has anorexia, what is the best treatment out there for them? And so we put this publication together. It's a free publication. If you're not aware of the Academy for Eating Disorders, even if you're not a member, you could go onto their website and download this document. It is quite thorough, and probably, I think we published it during COVID, so we're probably getting ready to gear up and sort of do another round of evaluations. But sort of the next slides are going to be part of, again, just very briefly reminding us all what is the standard of care or the best evidence-based treatments for eating disorders. So we know that weight stabilization and nutrition stabilization are really the cornerstone for any effective eating disorder treatment. So I think this is also one of the things that sometimes parents don't know. Well, my kid, and I'm going to say kid very loosely just because it's easier for me to say it, but I hope you understand that I mean that could be a young adult or even an older adult. In fact, I have worked with parents of loved ones who are as old as 45, where their loved one still had a very significant eating disorder. It's still their child, but anyway, I'm just going to use the word kid or child, but I mean the range of ages. So that, just talk therapy, there is really not much evidence that helps someone with an eating disorder. We know that there are components that are part of standard eating disorder treatments that are necessary. I often say to people, you can't get better from an eating disorder without eating. It's sort of like there's just no way. And that the standard eating disorder treatments include things like regular weights and vitals. Sometimes there is a prescribed weight gain or maintenance plan, initiation of normalized eating, fluid and food tracking, exposures, variety, decreasing food rituals and rules. These are standard to eating disorder treatment. Parents aren't always aware that should be part of the picture, because if someone comes and sees me and I say, well, when was the last time they saw a doctor? And they say, what do you mean? Then I know that they're not getting standard of care, right? So the frontline treatments, again, we're not going to talk about this a lot. I gave you, and you have the slides so you can go back and look at them. But the truth is, when we talk about children and adolescents, our frontline treatments are either generally FBT or CBT for eating disorders. For anorexia and bulimia, there are not currently established frontline treatments for binge eating or ARFID, although at this point, ARFID, there are emerging data on FBT and CBT for ARFID. There are these treatments that are out there. But again, leaves parents sort of wondering, well, what can I possibly do? For adults, there is a literal alphabet soup for eating disorder treatments. And again, if I was going to say, if I have a newly diagnosed individual, I am going to go to this manual and have a look and see what are the treatments that are recommended. Okay. So again, just so you have them, just so you know, and because I don't often, and this again gets back to the rationale. If someone comes to me and they say, I want med DBT, but they've never tried one of the other researched interventions that have more data and are often more succinct, I am going to recommend that they do that first, partly because I'm a scientist by training. Mm, At this point, I am more of a clinician and administrator than I am a researcher, but I like to hold dear what we know from science. And you don't generally start a treatment that's a little bit more experimental unless you've already done some of the things that we know by science to be effective, because we're going to start with that first. So again, just so you have them, but we know that, the data aren't good. It's actually a little depressing, even this far into my career, that I think you can say, like, on average, about half of people get better. That's kind of average. Some people, and the other standard of language about this is about a third of people get better, about a third of people waffle in and out of treatment, and a third have a chronic course. None of those numbers are great, right? So I think it is often the case that we're having to think outside the box. We've tried the evidence-based intervention, it hasn't been effective. And what else are we going to do? So I think that, again, because I'm not going to belabor the points of the evidence-based and what we already know, because that's not the point of my talk. But I think it's, again, as we're making this rationale for parents and we're saying, hey, we want you to try something that's a little bit different. We need to be able to explain the why. And part of the why to me is it's important to think about who traditional treatments were designed for and who they may not be adequate for, because that's part of, sort of making this rationale. And we know that you're in your standard randomized, RCT stands for randomized controlled trials, excuse me. In standard randomized controlled trials for eating disorders, there are groups that are excluded, because this is how research goes. It's not, I don't think that it's necessarily a fault of the research design, but we know that people who have, now, if they have psychotic disorders, they have substance use disorders, they have active suicidality, unstable medical conditions, or have recently participated in a similar intervention, will not be included in these RCTs. So when we talk about these numbers are already selected for people who would not have fallen into these categories. So when we have somebody who might be also suicidal, which, if you say that you do DBT, you get that you pull for a population like that. If you have someone who might have a comorbid substance problem, if you have someone whose eating disorder makes them unstable, then where are you supposed to go? If those treatments were not designed to help, or were the research that identified those people as eligible for the randomized trials, these people were already excluded. Where does that leave you? So I think there's that piece. And then what if my loved one didn't get better from those frontline treatments? We try, and these are the parents that we end up seeing at our clinic, parents who say, look, we tried, we did this CBT, we went to that residential treatment, we tried this IOP. Now, by the way, technically speaking, higher levels of care are not evidence-based. There are, I don't know of any. If someone knows of some, you'll tell me. I don't know of any randomized clinical trials that involve higher level of care, because you just can't do research like that. So that being said, most of the higher levels of care incorporate evidence-based components in them, but are not an evidence-based intervention in and of themselves. So we see these parents who say, my kid, I tried CBT, I tried FBT, we tried higher levels of care. My kid is still not getting better. Where does that leave us? And so, we know, again, and why did that come back up? I apologize. But this sort of gets back to this notion that, oh, by diagnosis. So part of what we know is not just by treatment. So the treatments themselves are about 50% effective. But then depending on the diagnosis that the person has, you will see that they have more or less likelihood to get better, with anorexia nervosa being the hardest um, illness for us to treat, partly because of its ego-syntonic nature rather than binge eating and bulimia, which are more ego-dystonic, meaning people don't like binging and purging. They want to stop that. Restriction is not necessarily something that people often will say, oh, I want that to be different. They want to feel better, but they don't want to necessarily stop the restriction. And then ARFID is, with the emerging evidence, and it was even interesting to me to put this talk together, and the amount of research that's come out about ARFID since we published those treatment recommendations back in 2020 has been fairly exponential. And one of the really interesting things to me that we're finding about ARFID is how hard it is to treat, partly because I think people see it as a bit more sort of generated by sort of the way people are in the world rather than a problem that has shown up in their lives. But again, if you look at these, not great numbers. So it is not uncommon that you're going to be seeing a family or an individual supported by a family where they have tried standard treatments and haven't gotten better. And if there are people out there who are young and interested in research, please do research. Please keep trying to think about ways to be able to help the people that we care about. So, who is not generally responding to treatment? Who are the people who don't get better? We don't know a ton, and this is also kind of frustrating about the field, but we know that the characteristics of individuals that make them less likely to get better are those who have emotion regulation difficulties, or I say that all at once, emotion regulation difficulties, recurrent suicidal and self-injurious behaviors, co-occurring disorders, meaning they have more than just an eating disorder, high expressed emotion and invalidation or psychiatric illness in the family, which makes sense, especially around families being able to execute FBT effectively, where is substantial ambivalence and a history of treatment interfering behaviors. And that's a DBT language, but this is where the individual or their family members engage in behaviors that make it difficult for them to get the full treatment model. Now, when you look at these characteristics that are highlighted, emotion regulation difficulties, reoccurrent suicidal or self-injurious behaviors, having more than one problem, high expressed emotion. Anybody not think about DBT? Because I think that it's like we've got the the ticket to say that would make sense for us to consider, which perhaps is maybe just getting a slightly bit ahead of myself. Because I think the other thing that we have to think about is what happens in treatment to people who struggle with more than one more than just an eating disorder. When you've got more than just anorexia, and I'm saying just as if it's that simple, more than just binge eating. What happens generally to people like that? We know that these people who have complex needs, now remember, I'm just reminding you, this is part of how we're making the case to families that we're going to try something different. So the people with complex needs are really, in my clinical experience, are the ones that are the most common focus of consultation requests. So although I run a clinic that does provide treatment, I also provide training, supervision, and consultation to other clinicians, but also to family members where they're saying, okay, you're an expert. We've tried X, Y, and Z. What else should we consider? It is often someone that has complex needs. These folks with complex needs are more likely to make up the population of those admitted to a higher level of care, and they are most likely to push therapists or organization limits. These are the people where people throw up their hands. Now, what are the people that have these complex needs saying about traditional eating disorder treatments? They say, okay, look, And if you look at what the research says, and when you talk to people who have had these experiences, they say, all right, look, that treatment that you forced me to do, sometimes it was necessary, but it was coercive, it was traumatic, it was invalidating. It had a very narrow focus. It basically said, eat, and that's it. It didn't look at the whole picture. It didn't look at my comorbidities. And it had a very limited view of what recovery looks like. So the people themselves, when if when you are working with families like this, you will often see that the again, the kids, for lack of a better word, are demoralized, they're hopeless, and they can be a little burnt out on treatment also, because it's like, look, dude, I did this and it didn't help me. Um, and we know that there are some structural and conceptual problems in the current treatment milieus. So, that the current eating disorder treatments are not really aligned to the needs of clients that are comorbid and multi-diagnostic. And the field, I think that we're trying to find some better language, but we can inadvertently reinforce this notion of severe and enduring. I mean, that's one of the languages that we hear that can also demoralize people in terms of them feeling hopeful themselves for getting better from their eating disorder, because we call them severe and enduring. Um, and that can inadvertently reinforce hopelessness, actually. We know that, the literature is asking us for, novel, nuanced, and evidence-based treatment pathways for people who are more complex. And you know, there's a recognition really that we can't just keep recycling the same approaches. On the other hand, I'm going to talk about this in a little bit. There is sometimes where we want to try something we've already tried. We can't throw the baby out with the bathwater always, but we need to think outside the box. So, let's just talk about a case example to give you a sense about what I mean by this. I'm going to give you an example of Carla, who, when we meet her, is a 23-year-old female at birth with a 9-year history of anorexia. She has presenting symptoms that are severe food restriction and rigidity with an intense fear of weight gain. As can happen, I personally believe that this is part of what is the invalidating environment for someone like Carla. She has a BMI of 19. And so people think you're not that sick, but her pre-morbid BMI was 24. And so she is actually quite weight suppressed and has, you'll see, intermittent medical consequences of that restricting, that can be, again, inadvertently invalidated because the number looks okay. Carla is binging and purging daily and sometimes multiple times a day. She uses laxatives and diuretics. She exercises intensely. She has extreme body distortion and dissatisfaction. That is not uncommon that we see in our patients with this sort of constellation of symptoms. She also has suicidality. Intermittently, she engages in non-suicidal self-injury via a paperclip or punching herself. But she, perhaps even more concerningly, has bradycardia and a prolonged QTC, which are both cardiac issues related to her eating disorder, which are life-threatening status, puts her under life-threatening status. Carla does not just have AN binge purge type, she also meets criteria for borderline personality disorder and PTSD. The PTSD is secondary to a trauma that she experienced as a high school student, and but also from some previous treatment that she'd had. Now, Carla, I mean, if you just were to look at those symptoms, you would say, okay, this is a complicated case, but there are significant behaviors that make Carla's care quite complicated. And we would call them in DBT, we would call them therapy interfering behaviors. But, depending on the framework that you work in, I think that you will agree that these are problematic behaviors that make treatment complicated. So for example, Carla shows up to treatment with us after having had a restraining order by a previous treater. Carla had, this is a very old case, and a constant, and I've pulled from several different cases, so to protect this person's identity. But this was in the early days of Facebook, and Carla made a fake Facebook account and friended the child of one of her other treaters, which became, when the parent figured out, the parent who was involved in Carla's care, obviously this became quite a difficult situation. And then Carla had a restraining order that was put on her as part of her status. Carla also had a relationship with group members that crossed boundaries and facility rules. She had offered other group members laxatives and diuretics. She had also created relationships that were private and that facilities that she came from considered problematic. Carla also had significant dysregulation that resulted in disruptive behavior as part of her treatment. She would, when I say, excuse me, I'm getting over a sickness, and so I have to make sure I stay hydrated. Carla had been in a partial hospitalization program and was hiding on the unit. She would leave to go to the bathroom and then hide, and people couldn't find her. She cried loudly in the hallway of the clinic. She ran out of treatment offices and engaged in non-suicidal self-injury in group. So, and to make things more complicated, Carla's parents were devastated, terrified, and had their own emotion regulation issues. Okay, I am not saying at all that Carla's problems are a result of her parents, but I think Carla inherited her parents' emotional reactivity and sensitivity. And the front office staff was very worried about Carla's parents because they were what they would call disrespectful and demanding. So Carla is somebody who, when we've, let me not get ahead of myself. Let's just think about what typically happens in a case like Carla's. If you think about the environments that you work in and think a little bit, I'm curious about it. If anybody wants to say, what do they think happens with a case like Carla's? You can either raise your hand or put something in the chat. But if you were in the environment that you're working in now, what would normally happen with Carla's case? Who would volunteer and say, yes, I want to see Carla? I'm glad to see some of you shake your head and they, right. She might be dismissed from treatment. There might be their treatment dropout. She would typically get referred out. Now, in this situation, again, because it's an amalgamation, but this was one of those cases where in my office, they were like, yeah, Lucine, you have to see her. We're not doing it. But generally what happens is the therapist is hesitant, won't see her due to liability issues. Like she had just had a restraining order because of her behaviors. The staff was like, I don't want to do that. Residential or inpatient gets recommended sort of almost out the gate. Like she calls in and they're like, yeah, we can't treat you. You should go to residential treatment. Now, I don't know if I put this in here, but Carla had been to residential treatment several times before. Staff see her as not wanting to get better, difficult, or hopeless. She starts to wonder the same because that's part of the message that she's getting. And she has been kicked out of treatment due to problematic behaviors or non-compliance. These are all things that happen to Carla. And I suppose so part of what I want to say to you guys, since you're here, public health service announcement, I want you to really think about if you say that you can't treat them, you can't treat this person, where are they supposed to go? Right? And if you're identified as an eating disorder expert, right, I really want you to think about that when a case like this shows up, you don't just say, sorry, no room at the inn. You say, I mean, if you can't for whatever reason, but that you are offering options to this person, because there's nothing. I have seen so many families where they're like, this place said no, she doesn't meet their criteria. This place said no, they say they can't treat her. This place says no, we can't do it. And so where does that leave them? Because I don't personally believe that there's anybody worth giving up on. So the other thing that happens is that Carla gets asked to leave treatment. She becomes demoralized and hopeless. She thinks nothing's going to help me. She starts to believe it. I must not want to get better. I am hopeless. What's the point of trying another treatment or starting over? So this is again part of what, when I talk to parents and they say, Carla doesn't want to come to treatment. Carla doesn't think this is going to help her. Carla is tired. I want to validate that that's probably all true, partly because of what Carla has already had to deal with. Now, by the way, I am not in what I love about DBT is we say you might not have caused all your problems, but you have to solve them anyway. So, and I'm also not saying that Carla doesn't have a part in this picture. Carla is not a victim. Carla is part of the picture, but I do want to validate that she probably doesn't want to do anything. And so what happens is when Carla gets asked to leave treatment or when Carla is rejected from treatment, parents are left as the de facto team. And they're all, now, first of all, if Carla is above 18, which she is, parents are often not included even in the first place. I can't tell you the number of times where I talk to parents and I say, well, what are the treatment people telling you? And they look at me like, what are you talking about? Carla's an adult. But parents are often not included in the first place. Parents are watching the behaviors continue. Parents not knowing, they're left not knowing what they should do. Not that they don't know what Carla needs, which is basically, what am I supposed to do? All right. So let me see. Does anybody remember what I was saying? Parents, that you can't get better. Parents are left to, all right. So parents know what they need to do, but they can't necessarily get their kid to do it, partly because, you have an eating disorder. And they think that, well, we have to work on these other things. We work on the trauma. We have to work on her motivation. We have to work on these other things before she's going to get better. So where does that leave treaters? I think that if you're assessing Carla for a new treatment, we might quickly consider a higher level of care. This is too dangerous. I don't know enough to help. I feel hopeless and helpless. And it leaves clinicians feeling rudderless, burnt out. And these are some of the things that you all wrote in the chat. This is unfortunately part of what happens. So then, all right, so that's how we get to DBT on some level, right? Because DBT is designed to help people who have complicated clinical pictures. Remember, okay, just reminding you, this is how we are making a case to parents that we're going to try something different, right? So now I've taken you through what works for most people, why it doesn't work for everybody, what are our options now that we know it doesn't work if you've tried those things, and we get to DBT. What is DBT? DBT is a structured evidence-based therapy that helps people with intense emotions, helps to reduce harmful behaviors like binge eating or impulsivity and self-harm and those sorts of problematic behaviors, helps improve relationships, combines acceptance and change. Again, if you need a summary on what is DBT, you can find it all over the internet. It's not what I'm going to do today, but just again, this is the trajectory of how we explain to parents why we get here. And well, I'm not going to get ahead of myself. What conditions is DBT effective for? We know at this point many things, including binge eating disorder and bulimia. Now, we have less data on anorexia in particular, but we're going to talk about that in a little bit. For whom does DBT generally work? DBT, we know at this point, is designed to help people across ages, across genders, across sexual orientation, across race and ethnicities, right? So we know that DBT is a broad-based treatment that has data for helping lots of individuals. It is a treatment that balances both acceptance and change. I will say, I came to DBT after I learned eating disorders. So I was in graduate school. I focused on eating disorders specifically. My job at this point in my life, because I have brought these two components together, DBT and eating disorders, I'm often either teaching eating disorder people about DBT, or I'm teaching DBT people about eating disorders. Now, I don't know where those of you who fall into this lie, but my experience, and I don't think there's data to support this, but this is my clinical experience, is those of us, and I put myself into this category, who come to this notion from eating disorders first are really good at focusing on change. We're good at problem solving. We're good at asking for people to do things differently. We're good at structuring meal plans. We're good at helping people prevent behaviors, change. Acceptance is a lot harder for us. Whereas those of us who are more on the sort of DBT end are really good at acceptance, maybe are good at change when it comes to suicidality and self-harm, really have a hard time at change when it comes to eating. And so our job here is to help people be able to hold both, because you can't do DBT without holding both. Standard DBT treatment includes, and this is important because again, I'm telegraphing for you. I'm terrible at telling jokes because I'm not very good at waiting for the punchline, because I always think I'm going to forget the punchline. And so the punchline of this is there are different kinds of DBT for eating disorders. And so I'm going to talk to you first about what is general DBT include, and then we're going to talk about DBT for eating disorders. So your standard DBT includes 4 primary modes of treatment: individual psychotherapy, group skills training, telephone skills coaching, and team consultation. Includes all 4 of those, partly because DBT, as designed by Marsha Linehan, was developed for people who are multi-diagnostic, complex, and possibly are going to kill themselves. A once a week individual therapy that doesn't include a bigger picture had not been helpful. And I would argue to you that someone like Carla, so this is again why I can't wait for the punchline of the joke, someone like Carla needs the whole picture. They need all of the pieces because their case is pretty complicated. So what is the structure? Individual therapy in standard DBT reinforces skills, works on motivation, is a year-long commitment in adults and 6 months for adolescents. We provide a weekly skills group that teaches emotion regulation, interpersonal effectiveness, distress tolerance, mindfulness. Those are the 4 main components. And when we talk about adolescents, we also teach middle path skills so that parents know how to best help their adolescent. We provide help outside of session, because for most people who have complicated clinical pictures, once a week for 45 or 50 minutes is not enough to help them with the multitude of problems they have outside of session. And we offer ourselves as access to be able to practice their skills and be more effective and divert crisis behavior outside of session. So we offer ourselves via skills coaching. And then the team, all of the people that are treating this individual, come together weekly to make sure that we're all on the same page and we're doing the treatment as best we possibly can. And we are not drifting from the model, right? That's standard DBT treatment. Now, the problem is if you take someone who is DBT trained, because part of, again, we're making this argument for parents. You tried this, you tried that, it wasn't helpful, you got a complicated kid, emotion regulation, maybe suicidality, maybe behaviors that are life-threatening that are related to the eating disorder. DBT makes sense. The problem is, if you go to a standard DBT therapist who doesn't know eating disorders, they are generally very comfortable talking about suicide and self-harm and managing the TIBs, and they're experts at behavior theory, skills teaching, and coaching, but it's fascinating to me how they can talk about suicidality and homicidality. And when I say you'll have to weigh your patient, they say, what? I have to do what? And they're not comfortable or understand current eating disorder psychoeducation or diet culture. They don't understand the medical risks and the needs. They don't understand, they're afraid of the nutrition. They think you have to be a dietitian to be able to help people. And they really hate talking about weight. And so it puts people at a deficit, right? So in my mind, when we were thinking about, yes, DBT made sense. And I haven't told you the whole story where, so I was trained as an eating disorder expert researcher, clinician, in my pre-doc and my postdoc. I learned DBT as part of my postdoctoral fellowship. Marshall Linehan came to where I was, Western Psych. I then accidentally, because of my husband, moved to Seattle and worked with Marshall Linehan while I lived in Seattle in the late 90s, early 2000s. But I really never had any interest in working with people with borderline personality disorder. I was an eating disorder person, but I had been trained, I had been intensively trained. So I mean, this sounds a little disingenuous, but it's really true. Like I needed a job and Marshall Linehan gave me one. Like that's the only reason I did it. I mean, 30 years later, it's like, oh, come on, Lucine, honestly. But I really wanted to work with eating disorders. And when I started to think about, okay, can I marry these two models? One of the things that was really clear to me is that you can't throw the baby out with the bathwater. We knew that there were standard evidence-based interventions for the treatment of eating disorders, CBTE. They didn't call it that then, they just called it CBT for eating disorders, FBT, IPT. We knew those things existed. And then we knew that there was this DBT, but it didn't sort of go together. They were separate. And so it was pretty clear to me that if we were going to treat clients with multi-diagnostic eating disorders, you needed expertise in both. One was not enough. And so this is how we get to the book that Livia mentioned earlier, is, DBT, we call it multi-diagnostic eating disorder, DBT, or DBT for people with multi-diagnostic eating disorders. It's a mouthful, but basically it takes the whole DBT, the standard DBT, individual therapy, all of the skills, which you'll see in a little bit is not true for the other eating disorder models for DBT. Consultation team, skills coaching, it's transdiagnostic. It's for any of the people with eating disorders. And again, I'm going to talk about how that's different from the other two models that are out there. And it marries these with, remember this slide from earlier, that that we know that in standard eating disorder treatment, there are components that have to be there. You can't get better from an eating disorder unless you eat, right? So we know that standard eating disorder treatments include regular weights and vitals, weight gain or maintenance, normalized eating, food and fluid tracking, food exposure hierarchies, increasing variety and decreasing food and rituals and rules, right? We talked about that in the earlier part, that those are the standard components of treatments that are specifically designed for eating disorder. And so the way that we thought about this med-DBT, and again, we're talking about how we're rationalizing this to parents, is it combines the cognitive behavioral techniques that are the cornerstone of the evidence-based treatments for eating disorders with full DBT theory and practice. So what does that mean? For adults, what that means is we take, CBT for eating disorders, all the things we know, the psychoeducation, the meal planning, the food exposure, the weight monitoring, the food monitoring, the medical monitoring. We do all of that and we combine it with standard DBT. Now, if you ever, I don't have it next to me, but Marshall Linehan's seminal work, that Black and Red book, is actually called the Cognitive Behavioral Treatment for Borderline Personality Disorder, right? So there's a heavy dose of CBT in DBT. So we know that there's an overlap, the change focus, the skills, symptom monitoring, behavior change. That's all consistent no matter which model you're doing. Now, if you know eating disorders, then you have to learn the DBT things, the focus on acceptance, the focus on emotion regulation, non-judgmental stance, which is hard for us who come from the eating disorder world. We tend to be a judgmental bunch. Again, I'm putting myself in there. Dialectical stance, acceptance skills, mindfulness skills. Those are the things that we have to bring together to be able to do it. So in my head, this is the image that I have. We are taking standard DBT and marrying it with standard CBT for eating disorders for adults. This is the Chris Fairburn Overcoming Binge Eating, which is sort of his guided self-help manual that actually includes strategies for helping people who undereat as well, but that we're marrying these two models. For kids, we are marrying the evidence-based intervention that we know for adolescents, which is FBT. parent-led meal planning, weight monitoring, eating disorder psychoeducation, monitoring the medical aspects with adolescent DBT. Parents are included. Parents are part of the picture. Parents are part of the treatment, no matter what. And so again, in the model is taking these two standard DBT for adolescents with FBT. I would say, and this is an overview, and the devil is in the details. It's not. I would say it's FBT informed. It's not as FBT structured as we would do normally, because these are kids who say, if you make me eat that, I'm going to kill myself. And so helping parents figure out how to get them refed while managing the suicidality and self-harm is an important piece. But it marries these two philosophical models. Now, the problem so far as I see it, again, if we're gonna say to parents, look, this is another model for you to be able to consider, is what is the research? Because if they don't ask you, you should tell them, because we want to be open and honest about what we know. Most studies that have evaluated this model involve case series and open trials. What that means is, randomized control trials are the most rigorous way to evaluate a treatment. This treatment has been developed in clinical environments. I would say that our clinic, UCSD, and some other clinics around the country have used this model, but they use it within a clinical setting and not so much as an academic evaluation. So we don't have RCTs. Again, if you're young and you're interested, this might be the thing for you to do. But we say that, but as a whole, what we know is that this model has shown to be acceptable, feasible, and efficacious in reducing eating disorder symptoms. So that's binging, purging, restrictive eating, and the comorbid symptoms when they're present. So we have some data, but this is why we don't start here, because there's way more research on standard CBT or FBT for eating disorders. Now, so when do you consider this treatment? And again, this is our best guess. When you have two or more of the following: traditional eating disorder treatment has failed. This is very important if you are a clinician who is trying to help a family figure out whether or not this model is going to be something that they should try. You want to evaluate whether or not they really actually got an evidence-based eating disorder treatment. I can't tell you the number of people I've sat across who say, well, I had CBT for eating disorders. Like, okay, tell me a little bit about that. Like, what kind of self-monitoring did you do? And they look at me like, what are you talking about? And I'll say, so give me an example of some of the homework you had to do each week. And they'll look at me like, what are you talking about? And if they didn't do homework and they didn't self-monitor, then they didn't actually get a dose of CBT for eating disorders the way that it's written. But if they have had these treatments and they haven't been helped by it, if there is emotion dysregulation that seems to be central to the eating disorder symptomatology, if there are comorbidities that would impact standard treatment, whether that be mood, substance, self-harm, suicidality, and if there is a history of significant therapy interfering behaviors, quitting treatment, hiding food, yelling at staff. If there are two or more of these, then to me it makes sense to consider this treatment, med-DBT. Now, part of the problem is people get confused because there are other DBT treatments for eating disorders, which are great, but they're not for people like Carla. So this DBT solution for emotional eating, we call this the Stanford approach. It's an adapted version. So first of all, it's shorter. So it's 20 weeks total. Not all the skills are taught. Skills and individual therapy are done in the same session, and it's only for people with better BN. Again, it's excellent. If you turn it over, I have an endorsement on the back. I mean, I'm not saying that these are not good treatments. They're just not for people like Carla, and they're not for the people that when the parents are showing up and saying, we don't know what to do with this kid, I wouldn't start here. Likewise, there's RODBT, which focuses on emotional overcontrol, rigidity, risk avoidance, restricting, basically designed for more specifically restricting anorexia. This is a treatment that is different. Like I think about it as a stage 3 treatment, not as a stage 1 treatment. It targets over control. It is only for people with anorexia. It prioritizes being flexible and having social connection, which again is great. But for our people who are fitting more of the model that parents come to talk to us about, we need to prioritize stabilization and safety before we're working on whether or not you're connecting with your friends or you're being more free in the way that you interact. It also doesn't have a model for how to address medical stability and sort of readiness for treatment. And again, it's an adaptation. So I'm going to recommend for somebody like Carla, we are going to go with med. Okay. Now, how is med different from standard eating disorder, like even standard treatments? This is the other thing that I like to talk to families about is that, they come and they often say, she's not choosing recovery. She's not recovery minded. I have to be honest, I'm still trying to articulate why I find that so difficult. And so, excuse me. So I had AI help me come up with this image because in my mind, when parents and treaters say, okay, they're not choosing recovery. I think this is what they imagine. They imagine our patient, and I thought it was actually really interesting because I gave AI the instructions I want you to give me somebody hiking up a hill. I gave the whole description and they gave me a man, which I thought, okay, I'm gonna go with this, which I like, let's go with diversity. But the idea is I think that families and treaters think recovery. Ah, there's this mountain. You're going to climb up it. It's sunny up at the top. Life is going to be so much better. This is how we think about it when we're explaining it to them. Okay. This is what I think your patient thinks. Recovery, first of all, I don't know what is up there. I have no idea what life is going to be like. It's cloudy. It's not clear to me. It's a long road. I'm not even standing up yet. I am sitting on the couch, exhausted. I've already tried recovery, whatever that means, a million other times. I don't know if I want it. And so, to me, part of what makes med DBT different is I am not asking people for recovery. I'm not saying if you want to do this treatment, you're going to have to recover or you have to come up with your model of recovery. What I am saying is, are you willing to stay alive and do what it takes to stay alive long enough for us to figure it out? I don't know. And I am also, and actually, again, because I'm not very good at the punchline, we just recently submitted this is the UCSD group and I just submitted a proposal to a conference. And I think that the way that we wrote this up to me actually captures it really well. MedDBT can provide an alternative to both rigid recovery models, like there's only one way to be recovered, and passive maintenance approaches, because again, this gets back to this like harm reduction, severe and enduring. We're not going to ask a lot from you by integrating validation, accountability, and an enduring belief in recovery, meaning that we are meeting patients where they are, and that never means that we're leaving them there. And to me, that is just a fabulous image. Like, I'm gonna meet you. You're on this couch, you're not even thinking about it. It's okay. I'm gonna meet you where you are, but I'm not gonna just expect you're gonna stay there, and I'm not leaving you there. Right? I am gonna help you think about what you need to do to stay alive, to take enough responsibility that we can figure out what your life is gonna look like. Continuing to connect behavioral change to the pursuit of a life worth living, which is again, standard DBT language. We want you to figure out what you want your life to look like, not what recovery looks like, what you want your life to look like. And that is what drives hope and progress. In turn, this can foster engagement and support the physiological and psychological foundations needed to sustain meaningful eating disorder recovery. Okay, so that language is really important. I think the other thing I talk to people about is taking away this focus of you need to gain weight. There is not a world in which you need to gain weight is met with a positive stance. Now, I'm not saying that our patients don't need to, our patients may need to gain weight, but I'm going to start back with having a life worth living means eating enough that you have enough brain power and energy to get up off the chair and start to even think about what you want to do. Study something, read something, take a walk, do something that and eating more to be able to have enough energy and to have enough brain space is the goal. Now, eating more than what you're eating now, or eating more adequately, or not having behaviors, or whatever it is, if you do those things in order to have enough energy, in order to have enough brain space, it's more than you're doing now, and your weight may go up. That actually is a reality, but it's not the point. The point is if you can eat more and have fewer behaviors, you will have more energy, you will have more brain space, and you will perhaps have more of a life that you want. And it may mean that your weight goes up, right? It takes a lot more words. I speak Spanish, and it's always to me, it's like translating something from English into Spanish, like something that takes 5 words in English takes 15 words in Spanish. And to me, it's the same idea. Like this, so recovery is way too limited a concept. Eating more to have more energy, to have more brain space, to have the life that you want may mean your weight goes up is actually the truth. I don't know what recovery is. Now, let's get back to parents. So I did a consultation recently, and the parents had heard about med, and they were like, we see our daughter all over this. Like when we read about it, we think this is what's right for her. Now, of course, it's the parents across from me, not the kid. And the kid's like, yeah, I'm not interested. Like, thanks anyway. I'm an adult. I don't want to do it. And again, I think that back to my neighbor, well, if she doesn't want to get better, I can't force her. Well, okay, I don't know. To me, how different is it than substance use? How different is it than, I'm not saying that eating disorders are like substance use, but how is it like, excuse me, how different is it than when you see your loved one doing anything that is harmful to them? You don't just say, oh, well, at least I don't. So, like, how can families get their loved ones to even consider something different because they've already tried a bunch of other things? So, first thing that we want to do is we want to ask them to ask the loved one to consider an informational visit. It's not even an assessment. I mean, if you can get them to agree to an assessment, that's great. But often these are individuals who are like, dude, I've already done everything. You're going to make me, it's a dog and pony show. I'm going to have to go talk to another person, tell them all my history. I don't know what's going to happen. I'm not sure I'm that interested. I get that. So, like, okay, will they even consider an informational visit? Can they read about it? Can they do a Google search? Again, and this is the thing to me that is important about working with parents is that we're saying don't give up. We can't force it. We know we can't force it, but we're also not going to give up. And we're going to continue to slice the bologna as thin as or the salami or whatever it is you eat. Slice it thin enough that it is something that the kid will be willing to do. Well, would you do a Google search about it and then we can talk about it? Can you read about it? Like, we're not saying you have to even go anywhere. Just read about it and tell me what you think. Like, so there are steps that we can ask parents to continue to nudge in the direction of being able to consider it. When they say no, when the kid says no, don't give up. And that if you have to, then part of, I think, what becomes interesting to me about what therapists have the possibility of doing is working with parents around setting loving limits. And I don't, and obviously this to me is it's its whole other talk. And so I'm just giving you an example. After you've had the informational appointment, I'm happy to pay your phone bill. After you've had the informational appointment, I'm happy to whatever it is that the kid is interested in, but that the parent has to be willing to make them uncomfortable, not give them the thing they want. If that is something that they think is necessary as a next step. And that's where I think therapists can be really helpful in figuring out what that is. I am not someone, I suppose, I don't ever like to say never because that's why I'm a psychologist. Like, I don't think anything's ever that clear. Like, I've never ever recommended someone kick their kid out of the house, or I've got a kid that's stuck in a higher level of care and the parents are being told, well, tell her that if she doesn't do X, Y, or Z, you're going to let her go to a homeless shelter. Like, I couldn't do it. I couldn't do it. I won't do it. But there are ways in which we can continue to have parents make the kid uncomfortable enough that they're willing to consider a next step. So your job as therapists is to not give up. If you feel like you are not an expert enough, refer to someone with more expertise or get your own consultation, right? If this is a family that you've worked with for a long time and you're not willing or they're not willing to go to someone else, fine. But then get yourself some consultation about how to help move this family in the direction of doing something different. Remember, families don't cause eating disorders. There's no data to suggest that families cause eating disorders. If anything, I often say to families, like you might have given your kid your biological vulnerability, your emotional vulnerability, but in general, you didn't cause this to happen. No one causes this. And no one wants it either, by the way. Continue to find ways to help parents set loving limits, create the environment that is less comfortable so you can nudge this person in the right direction. And again, nudge is the important word. Continue to help parents find treatments or interventions that are novel. Now, I'm not saying, and I said this earlier, I'm not saying that it's not okay to try something that you've already tried once, as long as there's a rationale. Like, I have certainly recommended, all right, you did CBT, but you did it with this person and you did it way back when, or you tried FBT when the kid was an adolescent and now they're a young adult and we're in a different place. We could do an FBT informed approach. We might try it again. But there's got to be a rationale. It's not just like, oh, it didn't work, so we're going to do it again anyway. And then have a model that that you feel like is the right next thing to do. And if it's not MedDBT, I mean, I'm not, obviously it's the thing that I'm most passionate about, but there are lots of other options, but you've got to have one. And then you've got to evaluate whether or not what you offered made sense, right? You want to be able to test and see if that model actually had the impact that you were hoping that it would have. If you want to learn more about MedDBT, we have a listserv, which you will not be inundated with emails. We just make sure that people know about trainings or books or articles. And so just send Anita an email. Again, you have this all in the slide deck. We have an intensive coming up in the fall if you're interested in learning more. We have some on-demand trainings that are available through our website, and we have a conference for this treatment. This will be our second year coming up next March. So I'm going to stop there and open for questions. I think we have a good 10, 15 minutes to see if people have questions or comments or want to ask anything about the model or the stuff that I spoke about.
Lucina, are those trainings for DBT therapists wanting to learn, like where do most therapists come from in terms of their expertise?
Yeah, so in terms of the intensive, then that's going to cover everything. It's going to cover the DBT you need and the eating disorder that you need. The ones that are on demand, we tried to, and we have more coming, but we tried to make them in bites of focus that are clear for whom they are best appropriate, right? So that there is more DBT-ish for people who know eating disorders, and then there's more eating disorder stuff for people who already know DBT. And hopefully that's clear when you look at the titles. But if not, just shoot us an email and we'll help you.
Any questions? Feel free to raise your hand or just talk or put it in the chat. I don't know if we have enough time. Like you said, it could be another talk, but I'm curious about working with the parents when the child is not willing to engage.
Yeah.
Yeah, that's a
I
long,
mean,
it's a
but listen,
big,
it's my, at this point, it's most of my caseload, right? It's working with parents. And I think there's a couple premises, like number one, we're not going to give up. Number two, there are some basic requirements, like as parents, you can say, you're living in my house, you got to see the doctor. And frankly, I do need to be made aware, like you need to sign a release for the doctor to talk to me. Not that the and we negotiate what that looks like. It's not like the doctor has to tell me and I'm talking about the medical doctor, because that's where, like, if things become dicey, somebody needs to know. And the idea here, and most people, if you are calm and persistent and you are you lay out your rationale in a way that makes sense and is not controlling. I rarely have a situation where the kid says absolutely not. But if they say absolutely not, again, we're not going to give up. So then we continue to have the parents make the kid uncomfortable. And what does that mean? Well, I'm sorry, I can't actually let you use my car because I don't know if you're medically stable. If you would let me, if you would sign this release so that I can know the doctor will only tell me if you're medically unstable, then you can use my car. But if not, I'm sorry, I can't let you use my car. So it's like rationale that makes sense, that fits the facts, rather than having it be arbitrary and have it be overly controlling.
and
You can't use my car unless your weight is exactly this and you've done exactly that. That in my experience doesn't work,
yeah. So
but when it's linked up.
along those lines, Kelly is asking a question I was thinking about too. How does MDBT differ from space in terms of parent work?
I don't know that it is informed by space for sure, because we use a lot of those techniques. We talk about accommodation. We talk about where that line is in terms of um, when is it reasonable to hold the limit and let the kid incur the consequences, and when can you not, because things are too dicey to be able to do that. But it very much, I think it's very consistent with that same concept of, if you do for your kid, you're accommodating, except when we talk about the eating, right? Like the eating is actually where the line gets very confusing for everybody involved. But from a, like, calling the doctor's office, making an appointment, doing all the things that might also be difficult and anxiety producing for their kid, and holding them accountable and not accommodating that, it's much more clear. But when you talk about, and I think the other piece is where DBT helps is the hierarchy. So you teach parents about, okay, when it's target one, no, sorry, I don't care that you can't do it. You have to do it because we have to keep you alive, right? But when it's target three, we have a bit more flexibility around parents having to do it for their kid versus letting the natural consequences occur. So I think that we map them onto each other. Hopefully that made some sense.
Thank you.
Yeah, you're welcome.
It sounds like you wouldn't reduce too much accommodation around eating, like around any rituals around eating.
Look, I think it depends. I mean, there are plenty of situations where I have done that. I've worked with parents around, yeah, your kid is your adult child, and this is an adult child. And again, I think it's different depending on each case. And I don't, these very complicated cases, I think I would be careful to not overgeneralize on almost anything. But there is an adult case where I was working with parents where their kid was on the verge of medical instability. And we decided, but the parents did have a release with the doctor, and the kid was seeing the doctor weekly, that them stepping back and letting the kid manage it themselves, because they had done full FBT. I mean, we made a very informed decision about this, but they let the kid do it herself, and she did flounder and did end up in a higher level of care. But there was a rationale for why we did it. It was neither just like, okay, that's it, I'm done, nor was it, I'm going to do this to teach you a lesson. It was sort of like, okay, look, we've tried X, Y, and Z. Let's try it in this model and see if the natural consequences will help her take more responsibility, but with very clear expectations around, she's seeing the doctor weekly. The doctor has access to the parents if needed, and keeping an eye on it. So unfortunately, it's much more nuanced, Livia.
Yeah, that makes a lot of sense.
Mhm.
All right, anyone else? Any questions before we sign off? All right. Okay, well, thank you all for being here. Again, I'm gonna put in, it would be wonderful if people could donate even $1, $5. The world is kind of going crazy. This is one way to take some control.
Absolutely.
So contribute to your community. Someone's asking about handouts. I did email the slides to everyone. I can send that out again in my follow-up email. You'll also receive questionnaires for getting your CEF certificate if you want that. And I think that's it. Thank you all for being here.
Right,
Thank you,
thanks.
Lucine.
Thanks for
Really
your
appreciate
patience
that.
with my internet. I better figure out what was going on with that.
Well, I'm glad it
Yeah.
worked out.
Yeah. Thanks so much. Take
All
care,
right,
everyone. Have a
thank
great
you.
day.
Take
Bye.
care. Bye.